off the internet. I added a few things onto the case study and added my own canned text questions, so I know it's kind of like a little study guide for liver, okay? So we're gonna extensively go through that today. I really believe this case study has everything you need to know for liver for the test. I really do believe that, okay? It really applies everything together. So the last part of the liver PowerPoint slides are like the assessment, the plan, the diagnosis. I'm bringing that to this case study, okay? So whatever's on there is kind of gonna be mirrored from this case study, okay? The study guide is out. I already posted that, so that's something you wanna start working on. And then the next part will just be the endocrine, okay? So I'm not saying endocrine is easy, however, we are gonna start learning probably a little bit today at the end of class. A lot of it is a review from patho. When we learned about patho of endocrine, it's all coming back, okay? There's really not anything extra that you're gonna learn except for the medications for endocrine, which is a couple extra questions on your test. The rest is pathophys of endocrine. So that should be at least a little comforting to know, like, okay, I've at least heard this. I know it's been a year, but I've heard this before, okay? And then Wednesday, what we'll do is we're gonna plan to have class in the library. Remember for ATI in the fall, we went to that computer lab? We're gonna go to that computer lab, and we're gonna do 9 to 11 is gonna be class first, and then we're gonna do ATI at 11. Most of you will be done with your ATI within an hour to hour and a half. You're gonna have to plan on a little bit longer day that day. So it might be 12:30 by the time you're done, okay? If this is a conflict for any of you, you can take ATI in the afternoon if you have to go do something for like choir. Do you have choir? Okay, I thought you did choir still, no? Okay.
It's done.
Okay, but if you, let's say you have a 12 o'clock appointment or something, okay? What you'll do is just don't take ATI at that time. You can take it in the afternoon or take it Thursday. It doesn't really matter when you take ATI, just as long as you get it done, okay? But if you have other obligations, please email me and we'll work it out. Okay, so Wednesday, do not come here, go to the library at 9, not 10, 9, make an appointment, make a reminder. We're gonna spend a good 2 hours finishing content, finishing endocrine, studying, reviewing, whatever we have time for. And then we'll take our ATI, and then test will be Friday, okay? So really for this test, you have liver and endocrine, okay? And that is what we have for our test. I really do think that we'll have enough time to cover it all. So 2 hours today, 2 hours Wednesday. And we've already done some liver already. Okay, due date wise, tomorrow, that is your ATI. I do suggest when the answers come out to this, study it. Look at the answers extensively, okay? Because even though I may not pull an exact question from this ATI questions, it's gonna be similar in the rationales of the answers. For example, if one of the answers is correct, but the 3 others are wrong, look at why those other 3 are wrong. You might see that come up on your test again. Please do not just say, I got 100, I'm not looking at the answers. Don't do that to yourself. Go look at the rationales when they come out for what the answer is, why it was, okay? Big tip for study for this test. And then Wednesday, before we take our ATI, the assessment A and B, a lot of you have already done this over break, but make sure you submit those with remediation. I've had to put a couple comments to say, show me what your results were for assessment A, and then do the remediation. So don't just submit your table with the remediation A and B. I want to see what your percent was to see what you kind of got wrong, so I can see how many things I'm looking for. Okay? And then the capstone reflection. Again, most of you have done this. It just needs to be something on paper. It's a completion grade. Did you go? Did you look at 3 presentations and a poster? You're good. You get your 100. Okay? So I'm not looking for APA format. Do not spend more than 30 minutes doing that. Okay? Do something to get it done. Submit it. And then Friday will be your test, and then what I'll plan to do for your final is next Monday, we'll probably have I'm gonna be here for 2 hours, and we're just gonna look at your whole semester as a whole and study for 2 hours if you'd like. And then the final will be next Wednesday, okay? So this final is comprehensive. It goes through all the units. I know it's a lot of information. I'll give you probably a study guide with this. It's probably gonna come out today. But this is something where it's all old test questions. I do not do new test questions. So at least you've seen it. If you come in for test reviews, you're gonna do probably a lot better than someone that has not come in to look at their tests, okay? And a lot of it comes right back to once you see a question you've seen before, okay? And this last little part here is whenever you take your proctored exam for Med-Surg, that's the one you'll have to do for assessment A and B, you'll have a week to do the remediation. If you would like, I can extend that to Thursday. If you want to wait until Wednesday after your final to do it, I'm okay with that. I can extend that. That's not a big deal. I just have to have grades in by Friday at noon. so if I'll probably say Thursday at midnight, I'll change that due date. Some of you just don't wanna do that when you're studying. Some of you wanna get it done right away, whatever you wanna do, okay? So I'll make a note of that to extend that till that Thursday. Okay. It's gonna be tight, compacted 10 days, but you guys, it's 10 days, you can do it, okay? I have full confidence that every single one of you are gonna be here in the fall, okay? So finish strong, put your head on, and get focused for 10 days. And then you guys will be done by next Wednesday. Isn't that great? Summer will be beginning in 10 days. It's amazing how fast the semester is. Okay, so what I want you to do is, this should be on your Canvas. I want you to pull up the case study. If you have not looked at it until today, I want you to spend about 5 minutes reading through it, and we're gonna go through the questions as a class. So you don't need to go through the questions, but familiarize yourself with the case study itself, and then we'll kind of go through it. So just read through it. I like what Amara's doing. She's highlighting pertinent information, because that's what we're gonna do as a class. Highlighting what is important, what is not. Just go through, and I'm gonna kind of pick on Amara because she's highlighting all this stuff. So I want to go through and just say, when you look at a test question, what are the pertinent things you need to know? And obviously we all know this is a liver cirrhotic patient that has all these complications, but I promise you I could get 20 questions from this liver case study. Easy, okay? So that's something reassuring to you that if you go through this and know it well, you'll be pretty good on your test. So Mr. Escobar is a 47-year-old male. I just want you to stop there. 47 old. If you say yes, I'm gonna not be up. I'm gonna be pretty upset. Right? 47 is not old. 47 is so young, right? We've seen some things in our past with nursing it's almost disturbing sometimes how someone so young can have so much longevity and do things environmentally that might result in a shorter lifespan. So 47 is not old. They have a history of cirrhosis, so we know cirrhosis in general is end stage, right? Once you get a cirrhosis diagnosis, you are end stage liver failure. Those are interchangeably the same things, okay? So he lives with his wife and his teenage sons. His wife brought him to the ED today because she has noticed that Mr. Escobar has increasing confusion and lethargy and was having difficulty walking. His wife states he's probably acting a little funny because he is sleep deprived. He hasn't slept very much in the past few days, okay? So I just want you to think about cirrhosis in general. Is there anything that you're thinking is going on? What's that, Sydney? Okay, so she thinks ammonia levels. So you're basing it on your diagnosis of cirrhosis, right? But notice if you just had, let's say you just had the top part. Does it say anything today about he's an alcoholic? Okay, so be careful about bias because we say cirrhosis must be alcohol induced, right? Cirrhosis is not just an alcoholic reason, it is in this case, and he's correct. However, don't assume that on your test. What are other ways that cirrhosis can occur? Think of other reasons why someone might have cirrhosis, not liver or not alcohol related. What's that? Infection, like, what's our main infection that affects your liver? Hepatitis, right? So Hep C, there could be a diagnosis of hepatitis C, hepatitis B, and they never got it treated, right? So that could cause cirrhosis too. Also, people could have fatty liver disease, and that could cause cirrhosis. So why would someone get fatty liver disease? Think about what they eat. High fat diets, high cholesterol, they probably have some type 2 diabetes going on. It could cause cirrhosis too. So just put that in the back burner that it's not just alcoholic cirrhosis. Okay? So let's just kind of put a little setting and some demographics here. He's in the hospital. He is African American. He does have cirrhosis secondary to alcohol. He's got high blood pressure. He does have some diagnosis of esophageal varices, which let's briefly talk about varices for a second. This is in the esophagus. Where else can you have varices in the body that's related to cirrhosis? Stomach, intestine, rectum, right? They can go all the way up your GI tract and all the way down. So even though if someone has esophageal varices, there's a pretty good chance this person also has hemorrhoids, okay? So think about bleeding tendencies. Ascites, okay, we're gonna talk about the questions below about more about this, but ascites does not happen in early cirrhosis diagnosis. This happens with end stage. Nobody's going to have a distended abdomen unless they are further in their diagnosis. So that little blurb should tell you about how severe this case is. He is unemployed, he has disability for the past 4 years. Maybe isn't relevant to this case study, but what about in healthcare could this be relevant? No health insurance, right? Or if he has a diagnosis of hepatitis C, is he going to get the care he deserves if he can't pay for his medications? He's married, he has 2 boys that are 19 and 17. He's got a history of drinking 1 quart of hard liquor each day for 13 years. And then he was diagnosed with cirrhosis 2 years ago. Right now, his medications are lactulose and neomycin sulfate, okay? So based on what you know what Sydney just shared, what are those 2 medications for? High ammonia levels, okay? How do we know they're effective? There's 2 ways. Lactulose and neomycin are gonna do very similar things. It's gonna make you poop, right? Just because you're pooping, does that mean they're getting better? No. What are the 2 things we're looking for? Cognition will improve, ammonia levels will decrease. That's what we're looking for. So if the ammonia levels are coming down, their mentation, their cognition should be improving. Their altered mental status should not be declining. They should not be getting more confused. They should be becoming more alert and oriented. Okay? Moving on down. He is afebrile. His blood pressure is 136/68. Pulse is 88. Respirations are 18. And then O2 sats are 98%. Is there anything concerning there? Not too bad, right? He does have a little bit maybe higher systolic blood pressure, but nobody in this room is running to go get meds quite yet, right? Now, thinking about the pathophys of cirrhosis, what is something in our liver that can become hypertensive that we get a little worried about? When it comes to splenomegaly, esophageal varices, ascites, there's some type of, you're saying it, right? portal vein, or portal hypertension that becomes, having that high blood pressure in there. So a lot of times people will be put on like propranolol, a beta blocker, to help with the pressure within that liver, and that will help some of those issues. He is awake, alert, and oriented to person only, so he's having some cognition issues. His speech is slow and he appears tired. The nurse notices a foul odor to his breath. Okay? What is that odor called? You remember? Can I bring this up at all? They have a certain type of breath.
Isn't it uremic vector?
That is more with kidney failure. Uremic fetor is like when their breath smells from kidney failure. It smells like urea. It smells kind of like pee. This is similar. When your liver fails, it's called fetor hepaticus. So if I say on the test, someone has fetor hepaticus, first of all, hepaticus is liver, and fetor sounds just like kind of what Taylor just said about kidneys, uremic fetor. It's a type of breath that is significant with liver failure. Okay? Upon physical examination, Mr. Escobar has slightly distended abdomen. What is it called? Ascites. The healthcare provider does not note any asterixis. So how would we assess for asterixis? We have them extend their wrist, and usually when they extend it backwards, it'll kind of flick like this, okay? What if the person is an alcoholic? Because this realistically could happen, and it's day 2 of their detox. What you might confuse asterixis for? Tremors, okay? So what's the difference? The person with cirrhosis that is not actively intoxicated or having withdrawals, we're past the withdrawal state, that is asterixis. Tremors are going to be consistent with detoxing, withdrawing 2 to 4 days after your last alcoholic drink. I will make it obvious if the person is drunk or drunk, okay? But make sure that you understand that those are 2 different things. One is withdrawing from alcohol, one is a sign of increased ammonia levels, okay? So when you have increased ammonia levels, I'm going to show you that probably, give you something that says, yep, they have high ammonia levels. And it's probably going to be someone that is not actively drunk or hasn't drank in the last 48 hours. Most people, when they're detoxing, by day 5, they will not have the symptoms of delirium tremens because they're already kind of past that point. But it takes about 5 days. It takes a while. Okay, it says here the healthcare provider requests an abdominal ultrasound which reveals fatty infiltrates of the liver, an enlarged spleen, splenomegaly, a polyp of his gallbladder, and a moderate amount of ascites. Okay? So probably some things we already knew based on his diagnosis. Let's go through the laboratory findings. So starting with our CBC, why are the white blood cell counts, the red blood cells, the H and H all low? Let's just think about what's the rationale. There's really one reason why they're all low. Yep. Okay, so when you have portal hypertension, which really, any person that has cirrhosis is going to have portal hypertension. It's one of the factors that is pretty consistent across the board. When that hypertension occurs in that portal vein, it shunts blood over to the spleen. It's not having as much blood flow to the liver. So when it gets shunted to the spleen, what does pooled blood do? It kills stuff because it's warm, right? We want blood to be continually flowing. Blood is not clotted off there, it's just not flowing as nicely. So when blood sits there, it's 98.6 degrees, it's going to kill cells that are in that spleen. So your white count, your red blood cells, and sometimes your platelets too, we just don't have platelets on here, but those 3 factors are going to be low, okay? We already have a high chance for bleeding because you probably lack which vitamin? Okay, so now that we have shunted blood, we're destroying our red blood cells, we have low vitamin K, and now we have esophageal varices. Think of all these risk factors that are going to be high risk for bleeding, huge risk for bleeding with liver, okay? Going down to our CMP, what is different from a CMP and a BMP? So really, this is consistent with your BMP. B means basic, okay? C is complete. Whenever you see a CMP, it's because the provider wants to know more about this organ, liver. C means liver, basically. So when you do a complete metabolic panel, we're going to do all these liver function tests that go with your liver to say, is your liver inflamed, stressed, or not working? So looking at the 6 factors that goes on to the next column here, those 6 factors are going to be your friend for this test. You have to know high and low. I'm not gonna say what's a normal protein, what's a normal bilirubin, what's a normal ammonia. I'm gonna say high or low, okay? So I might put something like this, where the AST and ALT I put normal is this, here's your result. So you know it's high. So I might not have put elevated, but you can see what normal is and determine if it's high or low. Same thing with ammonia. I just put high next to it, so you knew what it meant, okay? So looking at these labs, does anything look concerning to you in the BMP portion? So just the part that's highlighted. Okay, your bun and creatinine are a little bit higher, so is my kidneys getting a little stressed? Yes. Your glucose is 185. Maybe there's some diagnosis of type 2 diabetes there that's not been diagnosed. Everything else is okay. Okay, there could be some up part of normal, but everything looks fine otherwise. So let's go on to our CMP portion. So protein and albumin, I would put them together as married, okay? Because these are going to be factors that identify what problem in the body. Nutrition, right? So albumin and protein has a lot to do with nutrition. What do we know about alcoholics? They don't eat like we would normally eat. I'm not saying they don't eat ever, but they don't necessarily eat the nutritious things because they're drinking all day. So protein and albumin, believe it or not, is a very high probability that someone has liver cirrhosis because it takes 3 months for your protein and albumin levels to decrease. So if you have a bad week where you eat crappy, or like you don't eat really anything because you're sick, your protein and albumin levels are not going to reflect it. Now 3 months and you're like that, which that's a long time to not eat very well, then it's going to start to decline. So one of the best labs for liver cirrhosis is your protein levels and your albumin levels. Or if someone is malnourished, really malnourished, you'll know that from those levels. Okay? What happens when you lack protein in your blood supply? So this kind of goes with like pressure within your vessels. So if I don't have huge molecules of protein floating around my blood vessels, what does blood or fluid tend to do? Leak out of the space, right? It loses that tightness inside of that vessel and it kind of leaks out the space. So this is where your ascites comes in, or this is where swelling will come in with people with low protein. So have you ever seen someone like in the nursing home or even in the hospital that is severely malnourished and they just get edema everywhere or swelling? It's because of that lack of protein inside that vessel. Okay? Bilirubin, I give you a 3.8, which isn't crazy high, but it's high. What would the person may look like? Didn't say it in the assessment, but could. Jaundice, right? So bilirubin is a sign that your body or your liver is not secreting the bile like it's supposed to, okay? And if that is the case, the bile kind of circulates in the blood, it doesn't come outside the stool. Okay, think about this question. Why do people with cirrhosis have clay-colored stools? So what is poop? Why is poop brown? Bile. If bile's in your bloodstream and not inside your digestive tract where it's supposed to be, that's why your poop doesn't get brown. So somebody that has clay-colored stools, like a white chalky color, that is a bad sign. That typically means liver problems, okay? So if you ever see stool that is not brown or the typical colors, it's more lighter colored, they should have their liver looked at. Okay, AST and ALT, they're high. What are those functions doing? And what is that for? Those are your liver function tests, right? So which one did I say is more consistent with alcoholism? AST, okay? Now, could a person have cirrhosis for 20 years and those two factors be normal? The answer is yes. So it's showing here he has an acute inflammation. It might be something where he's kind of now getting to the point where it's acutely inflamed. But he could be having cirrhosis for 20 years and then he never has those increased. All right, ammonia. There's probably one of our biggest factors of this whole case study. It's why he's having all these signs. The ammonia is high. Okay, why did I put a coagulation study on here? What is that relevant for? Vitamin K, right? So if vitamin K is severely low, you're going to see it reflected on your coagulation. So your PT-INR and your PTT. Are you nervous about anything there? I know those normal lab values. Not really, no. It looks okay. All those are pretty much normal. So, is he at risk for bleeding? Absolutely, 100% yes. Is he actively bleeding? No. Okay? So that is significant to know for your test too, because I'll put in the question. They're either bleeding or they're not bleeding. So you're either going to treat the bleeding or not treat the bleeding based on what you see for labs. So for your test, I would know these labs for sure for your test. These are probably the ones I'll pull up. I think there's probably nothing else besides these labs here. UA, we just put normal limits to rule out infection, to make sure he's not having like a UTI that would cause confusion, those kind of things. So nothing with the urine analysis. So this is what the healthcare provider wants to do for this patient. They want to do a gastroscopy, which why would they want to put a scope down someone's esophagus? They want to look at those esophageal varices to make sure they're not bleeding. What is a risk factor by putting a scope down someone's esophagus? They could rupture the bleeding, right? So they have to be very careful. And then they're going to see if there's anything there. They're going to give some fluids. Why would you give fluids to someone that's retaining fluid? Right, so where is the fluid in this person's body? Out of the vessels, right? So this person, even though his protein is low, he still needs fluid in his vessels because he doesn't eat or drink, right? Or he might be having issues with consuming fluids. Medications prescribed includes lactulose and neomycin sulfate, which are 2 meds for ammonia. The healthcare provider admitted him to the hospital. They want daily weights, okay? So even though some of this stuff is done for you, for interventions, every person wants daily weights and I-know to see what is going on with that fluid status. We want to make sure that ascites is not getting worse. And it says monitor for stools for occult blood. So has anyone ever had to check for blood in the stool yet as a nursing student? I think we brought this up. How do we do it? You poop in a hat, you get a little stick, right? You put it on the little paper that it's kind of like a little pH paper or like the little flat book that they have. And then it will turn positive, it'll say it turns blue. If it's positive, and it means they have blood in the stool. Not every person has frank red blood where it's obvious. It might be darker, tarry colored, really black in color. So just be careful that we understand that blood does not always mean red blood. Now, if you saw bright red blood compared to dark, you know where the location is though, right? So bright red blood is typically lower in the GI tract. Black is upper, so maybe it's in their stomach. Or what if it's in their esophagus and it's going down the tract, right? So side note, GI bleeds if they have a lot of blood in their esophagus, a lot of blood in their abdomen. If they digest that, it turns into protein. It literally is byproducts and it turns into like a protein. So if you have a GI bleed going on in someone with an ammonia level that's high, you can have a higher risk for high protein inside of that body. So the person could have worsening ammonia levels. So we do not want these alcoholics to have GI bleeds. Okay? Neuro assessments every 4 hours. Could you do a neuro assessment more often if needed be? Of course you could. That's the bare minimum. We would not do neuro shifts once a shift on someone that is acutely confused, right? We want to, every time you go in the room, you're doing a neuro shift, you neuro assessment. Why do we want low protein, low sodium diet? What does protein break down into? Essentially, it will break down into ammonia. So it breaks down into urea, goes into an actual ammonia state. So the more protein this person has, which you're probably thinking, well, their protein's low, I want protein, right? It's a catch-22. But if you give too much protein, it's going to cause higher ammonia levels. What if we get their ammonia levels back to normal within a week? They can start reintroducing more proteins, right, inside of their diet. That would be okay. What about sodium? What does sodium going to do for this patient? If I give a lot of sodium, what comes with? Fluid, right? Another thing is when they have sodium that is lower inside of the body, it's going to help with your blood pressure too, right? We don't want that portal hypertension if we can avoid it. Okay, so here are our questions. And this is pretty much your study guide for your test based on what we have. So he does have cirrhosis. We want to talk about the pathophys. So when you get a cirrhotic liver, initially, what is the size of your liver? Is it big or small? So when you get an inflamed liver, the early parts of cirrhosis, what is the liver size? Big. Did I tell you about my patient we had in the clinic a couple weeks ago? It's probably been a month now. Usually your liver should not be felt. Most of the time in health assessment, when you guys assess your livers, you're like, I don't feel anything. That's a good thing, okay? You don't want to feel a liver. But the liver margins should not really extend too much past your lowest rib cage, or that rib in your rib cage. If you're feeling it past that rib cage and you're not having to like dig for it, that's an inflamed or a hepatic liver that's big, okay? So as it first gets diagnosed, it's large, but eventually it turns into like scar tissue and it eventually shrivels up. So when you get to an end-stage liver cirrhosis, where they are pretty close to death, that liver just shrivels up, okay? So what they will do is when they are able to get a liver transplant, they will take a portion of the liver, not the whole liver, okay? So just a small part of that liver, okay? Number 2, briefly explain how hepatic encephalopathy is related to cirrhosis. So we'll just bring up Sydney because she brought it up. But when the person gets cirrhosis towards the end, they will start to build up those ammonia levels. And they will tend to circulate that through their body, and it will eventually end up in their brain. So if someone is confused, alert and oriented is not ×3, we need to check an ammonia level, or assume that that is high. And I will provide all ammonia levels for your test, so you'll know. Okay, so the healthcare provider did not note any asterixis. What is asterixis and how would one assess for it? So we did already cover this, but I want you to really think about the difference between tremors from alcohol intoxication, or when they're withdrawing, and asterixis. Okay, I'm going to repeat it again. So asterixis is consistent with high ammonia levels, typically when they have not drank. So someone could have end-stage cirrhosis, they quit drinking because they have gotten to such a bad state, it's been 2 months since they drank. Tremors will happen in the first 2 to 5 days after alcohol intoxication. Why does it not happen before 2 days? They're still drunk, okay? When people's BAC levels, their blood alcohol levels, are severely high, you're not gonna get the blood alcohol down to 0 until about 4 to 8 hours. Now, for someone that drank last evening and they had a lot of drinks, okay? You drink once in a week. Your blood alcohol level takes about 12 to 16 hours to go back to 0. Why does it take an alcoholic 2 days? Correct. They're drinking all day, they're on a bender for days and days and days. They never get back to 0. So when they get to, even just a small amount of liquor in their blood, they tend to start from a higher number, okay? So they're gonna take a little bit more time. Which brings up a good point. When do we usually start doing CWAS scales? 48 hours after their last drink. When you have a person come in drunk to the ED, you can start CWAS scales right on admission, but you're not gonna get a positive until when? 2 days later. Yep, and that's when they'll start giving medications. Okay, number 5, identify 3 priority nursing diagnoses. So this is what I'm pulling straight from your PowerPoints that we have not looked at yet, or we haven't formally looked at these. But let's just think about what is going on with Mr. Escobar and things that would be concern for him. Excessive fluid volume, and this volume is not in the vessel. This excessive fluid volume is where? In his stomach, or his ascites in his stomach. So even though there is excessive fluid volume, this person's volume has to be taken off in different ways. We can give diuretics, we can try to see if that'll work. However, what may need to happen for this patient? What kind of procedure that takes it off? And some of you maybe have seen this too. Paracentesis, right? The big needle goes into the stomach, it pulls off the fluid. Well, why don't we just deflate it all and take it all off? Your body cannot do fluid shifts like that. It has to go slowly. So they might do one today, take a day off, and do another one in a couple days. What would happen if the ascites got so bad? Huge belly. We've all maybe seen it as a picture, and it's so large. What's going to happen to this patient? Because the fluid's just sitting out into that third space in their stomach, but it's going to put pressure on your lungs, and they're not going to be able to breathe. So it's kind of like when people have truncal obesity, their belly gets really big. They lay flat, what's going to happen? It's all going to get pushed up, they can't take deep breaths. So what position do people with ascites like to be in? Upright. They do not like to be on their back. They cannot breathe. So put the head of the bed up. All right, let's think about the mental aspect here. What are some things here we could put for nursing diagnosis? What's that? Yeah, acute confusion. So it's acute, right? This is not a chronic thing. This person is acutely confused. It's related to the increased what in the blood? Ammonia. And as evidenced by, he's lethargic and he's saying stuff that doesn't matter. He's not alert and oriented ×3. So what would be a huge risk factor here for someone that is acutely confused? Think about in the hospital. We've all had that patient, right, Adam? When a person is acutely confused, what's our hugest concern? Falls, right? Because they don't know where they're at. They're going to make decisions that are not rational. They could fall out of bed, and they might even get to a point where they're agitated or belligerent, okay? So think back to before break, we talked about a medication we can give to patients that become very confused, but more as a self-threat to themselves where we need to medicate them. What do we give them? What's that? Do we want to give them really strong CNS depressants? Like meds that would make them go sleep? I'm going to show you the PowerPoint so you know exactly what to give. Why do we give this medication and not lorazepam? Because it's the same family, it's a benzo, it's a CNS depressant, but what's special about this one? Okay, I mean, we can give lorazepam for acute agitation. Lorazepam takes about 12 to 14 hours to exit your system. This one ends in about 2 to 3 hours. So it's about half-life, it's a shorter half-life, and we don't want it to stay around very long. It's kind of putting a Band-Aid on a bigger problem, but could we get some doses of lactulose and neomycin in this patient to maybe help their confusion, and this can buy us a little bit of time? Yes. So we want to make sure we give them short-acting drugs that are not going to cause severe lethargy, because what are we trying to do here? Not make them so lethargic, that's kind of the point. So we're trying to make sure they're safe though. We don't want them to get too snowed. Okay, other things for risk for falls. Think back to your core classes of nursing when we say, what are fall risks? How do we prevent falls? And some of the consistent things we're always doing. The bed is low, right? Bed rails are up. Not all four, because that's considered restraints. Call light within reach. Make sure the floor is clean. Make sure stuff is within reach to the patient. Water, those kind of things. Using the call light to get up to go to the bathroom, okay? Frequently checking on your patient, right? At least every hour for an acute confused patient, if not more. Okay, let's do imbalanced nutrition. That's another nursing diagnosis that might come up on this test, but also the interventions that go with it. So imbalanced nutrition, is it more or less than body requirements? Less, right? So we don't know exactly what this person eats. We haven't evaluated that. Now, I never say to assume, however, this person might be a textbook alcoholic cirrhosis patient where they just don't consume a lot of calories. So what kind of diet would we suspect for this patient today? The low protein, low sodium, but I would put higher calories if we could, because this person does need to gain probably some weight or to have other sources of nutrition. They might, if they're so lethargic and they can't eat, they might get peripheral nutrition through the vein. They potentially might need that, if that is something they would need at that time. What about fluid? We want to encourage a lot of fluid here. They probably will get it through their vein, but they are not going to probably have tons of oral fluid. A, because they might choke and aspirate, but two, because they do have significant ascites. Okay, next one, number 6. Identify which of the client's abnormal lab results are abnormal and provide a rationale for why each is above or below. I think we did that with the labs, okay? But hopefully you're listening to which ones are relevant. Okay, so with ascites, how do I know, let's say Amara's on the day shift and Max is on the night shift, how do I know that ascites is getting worse based on assessment? If Amara goes, belly's big, and Max goes, belly's big, and then Talisa works the next morning and goes, belly looks small to me, you have to measure. You have to measure the abdominal girth of the stomach. So where do you measure? The biggest part, okay? So you just find the biggest part and you measure that, and they will measure it every single shift. You especially will monitor it before and after a paracentesis, because you want to see how much is off. You will definitely measure the output of what comes off of the stomach. It could be 2-4 liters of fluid, or they can do the GERT to see if it's actually getting better. But you can never just say, stomach looks big, must be big. Okay? It could be bigger, 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 and then you don't know what's here's. Why is weight not a good indicator, or I should say, why is weight not the best indicator for ascites measurement? Like, if, let's say today they were 150 pounds, tomorrow they're 155 pounds. We don't know where that fluid is going. We don't know if it's in this inside the vessel, inside the ascites. So even though weight can fluctuate, we still need to measure the GERT to know, is it getting pulled off there or not? Okay, Mr. Escobar has been prescribed lactulose and the neomycin sulfate. Explain why each of these meds have been included. So So what were the two things I said that you'll know that they're working? Level of consciousness, cognition, and ammonia levels will come down. Why is stools not enough? Even though they probably will poop more, that's how this is working. They're pooping out all the ammonia, that's what the goal is. But just because someone has 5 bowel movements, they might need to have 50 to get all the ammonia out of their body, right? So we don't know if that's even enough. You have to go on their cognitive functioning. And it will be obvious as the day goes on, they'll probably poop a couple times, and they'll be fine or get better. Okay, and then it says low protein, low sodium diet. I want you to think back to what sodium does to fluid. We have low sodium, so therefore the fluid won't be retained. And the protein, when it's inside of your vessels, usually if you have that protein that's low, it's going to make the fluid kind of fall out. But in this case, when their ammonia is high, we have low protein so it doesn't get broken down into ammonia. If the person has cirrhosis, do they always have to have a low protein diet? The answer is no. Okay? We never encourage high ever, but in a case that, let's say they have cirrhosis, they're not hospitalized, they're not having high ammonia levels, can they have some protein? Yes. And we just encourage them to have it, maybe for one meal or smaller meals throughout the day. What are examples of protein in the diet? Let's think about some foods. So you might get a nutrition question where it says, here are your 4 diets, which ones have high protein? Meat, right? That's gonna be your number 1. Eggs and milk are high in protein. Any meat matters. So steak, chicken, fish, those are all high protein. You could probably say peanut butter. I would probably make that a limited one, but protein is not that high in peanut butter. I mean, it is a little bit, but it's not crazy. But your dairy, your meats are gonna be your friends for this test. If you see those, do not give those to liver failure patients with ammonia that are very high. Not a good option. Okay, so the gastroscopy reveals that Mr. Escobar has esophageal varices, which are treated with banding. So they kind of like clotted them off with a band. Discuss what esophageal varices are in the banding procedure used to treat them. Okay, so I always say, think about varicosities of the legs. We've all seen people with varicose veins on their legs. Now picture that inside of someone's esophagus, where it's just kind of coiled and it's in the way. What are things we will do to protect them from getting them ruptured? What kind of foods would we not want them to eat? Yep, we want softer foods or things that are not sharp. So seeds, chips are not good options for people with esophageal varices. What are other things that are gonna maybe make them rupture? Think about exercise. Like the plyometric exercise, like ab workouts where you do planks and you're like grunting, heavy lifting, like actual like bench press and things that cause a lot of strength to be compressed, right? Aerobic exercise is the best thing we can encourage for people that have esophageal varices. Alcohol, what does alcohol do to your blood? It thins it out, right? So those are things that we would encourage them not to do. That's one of the reasons why they have it, but stopping alcohol. And then coughing. So let's say they get a cold, okay? An alcoholic with esophageal varices comes in with a cold. We want to put them on a cough suppressant, okay? We do not want them excessively coughing a lot, okay? What about if the varices are in the rectum? What would be one way we can help them not have them rupture down there based on the other end? Fiber intake is good, keeping that soft stool, so they might need a stool softener if they have a very hard stool. What about straining? People that get on the toilet and they're just pushing. That is bad, that's causing a lot of pressure down there. So softening the stool with fiber or meds might be encouraged, okay? Okay, remember when I talked about bleeding risk with liver? If someone is on a bleeding precaution, and I talked about like the razor, it was just like a razor blade. I was looking for something fancy, but like they should not be using razor blades, like the ones where they shave their face, like not with the bzzz, the electric, but the razor blades, no, those are a big no. Also, shaving their legs, even if it's female, no razor blades. They should use electric or other forms of hair removal. What are other ways we can prevent bleeding with bleeding precautions? So think of other things that would cause bleeding in a patient. You're Sydney, someone of that. Max, what do you say? Taylor? I hear little voices, I just don't know what you're saying.
Shots, injections.
Okay, so we avoid IM injections because deep into the muscle, there's more chance for bleeding. So if they have an IV, let's try to get as many meds down that IV as possible and not trying to poke them a lot. Would a person that has end-stage cirrhosis be a good patient for a student to practice on? No. You want to have someone that's good at IVs, you get it in one time, avoid the bleeding, okay? So avoid extra sticks if you can. What about toothbrush? Soft bristle toothbrushes. Hard bristle ones tend to make your gums bleed. And then yeah, stool softeners, if you happen to have someone that's straining, that could cause more issues, or the chips when they're eating, those kind of things. Okay, just 2 more things on liver, and then I think you got it. It's not so bad, right? Liver's not so bad. All right, skin integrity. When they have their high amounts of bile salts on their skin, so when people have cirrhosis, they tend to get very itchy, and it's because it kind of collects on that skin. Another factor is the ascites. Once it gets super tight in their stomach, they want to scratch it. So what are things we can do to prevent bleeding or infection because they're so itchy? Keep their nails short. They can take medications like cholestyramine. Remember, that's a medication that kind of helps with the bile on the skin. And they take it just in a little drink. What about when they bathe? What are some things to avoid to make your skin not get dried out? Warm water, not hot water. Hot water will make your skin dry out. Soaps that have scents, avoid scented soaps. Those tend to have more alcohol in them, and alcohol inside of soaps will make it dried out. Okay? They can use lotion, that's encouraged, but avoid what kind of lotion? Scented. Just try to make it unscented if you can. Sometimes if it's really bad, you guys, these end-stage liver that are very mentally not capable, we put mittens on their hands. And it's because they're like scratching so bad where we don't want to restrain them, but they'll put mittens, like literally mittens for like cooking, hand mittens, and then they'll tape it, and that way they don't like scratch open their wounds on their skin. So it is common. Okay, the last thing we're going to talk about, and we'll take a quick break here, is when somebody has esophageal varices and they have to have those, it's called a Blakemore tube. Remember we talked about that tube that goes down, and it puts pressure, they inflate the balloon, it puts pressure at the bottom of your esophagus on those varices. It's kind of like if you have a bleeding wound on your arm. You put pressure on it, and what happens? The bleeding stops. It's the same concept, except for this balloon goes down their esophagus, and the top part of their stomach and the bottom part of their esophagus, and puts pressure on it. What was one of the concerns we had with that device? What's that, Kaylee? Yep, so let's say it migrates up. Sometimes it'll come up and it can actually put like pressure on your trachea, and it causes them to not breathe well. So what do they want you to have at the bedside at all times? Scissors, okay? If the NCLEX asks you a question about a Blakemore tube, which is called a balloon tamponade, that's what those tubes are called. You gotta have scissors at the bedside, and that's what they're gonna ask you. So how would you know it's time to use the scissors? We don't just cut every time we feel like there's a feeling. They become hypoxic, they can't breathe, and you have a feeling like it's been increased, it's migrated up. Hopefully that won't happen, they can deflate the balloon, there's no problem. Okay, so scissors at the bedside. Another concept too with that tube, they like to put the head of the bed up. Why would somebody with esophageal varices want their head up and not flat? It's like gravity. Blood should go down and not pool in the esophagus. So we want the blood to go down, head of the bed should be up more. Okay, so more than 45 degrees. Okay, that's all I had for liver. You guys can take a break, and then we'll start ending.